This is the end of chapter 25, skin disorders. I put you a picture up here that just basically shows you the levels of the skin, the epidermis, dermis, and the hypodermis, and where the hair follicles and sweat glands and connective tissue kind of fit in. The first skin disorder we'll be talking about is psoriasis. Psoriasis is an autoimmune disorder. It affects the skin a lot like lupus does. You can have exacerbations, you can have remissions. Psoriasis results from an overstimulation of your immune system. There are specific cells called Langerhans cells. These cells activate your T lymphocytes. Your T lymphocytes go and target your keratinocytes, and this is all of this causes an increase in your cell division. And then you also have plaque formation, which you can see here in this picture of the psoriasis itself. It's a buildup of plaque, and then you have a lot of inflammation around the bottom of that plaque. Realize that your normal basal cells take about 28 days to go from deep in your tissues. They reach the outermost layer where they're normally shed. In a person who has psoriasis, the rate of cell division is sped up so much that these cells, instead of shedding every 28 days, shed every 4 to 5 days. So you might ask, what leads to the outbreaks of psoriasis? Many things can trigger this particular disease process. There is a phenomenon known as Koebner's phenomenon. And this happens when you have an area of skin that has been injured in the past, say like from previous trauma, if you've had a car accident or you fell down and injured that area, or you have had a broken bone or an open wound. This tissue tends to be a lot more susceptible to the development of skin problems or even cancers. And even areas that have had surgery in the past, sunburn, or just inflamed. Patients with psoriasis sometimes can improve with sunlight. That doesn't mean you want them standing out in the sun all day long. And factors that can make this particular disease process worse are throat infections, upper respiratory infections, basically any type of an infection, hormonal changes such as menopause or puberty, stress on the body, some specific medications like beta blockers, obesity, and of course the presence of other disease processes. Patients that have psoriasis can also, this can develop into a arthritis called psoriatic arthritis, and you may have seen some of the commercials on TV with the pro golfer. Psoriatic arthritis is actually worse than rheumatoid arthritis. It leads to severe joint changes and is seen in rheumatoid arthritis. This is another picture. It just shows the psoriasis in a Caucasian person, and then how the difference is in the African American person. So the treatment for psoriasis, first off, are corticosteroids. Steroids, as you all know, have anti-inflammatory actions. When applied to these lesions, they help to suppress that cell division and slow it down. Whether the steroids are effective or not depends on the potency and ability to be absorbed into the skin. So the more potent the corticosteroid is, the better it will be. A lot of times it's helpful if you use like warm moist dressings and use an outer wrap of like plastic or gloves to help enhance the absorption. Tar preparations can be applied to the skin to help suppress that cell division. They also help reduce inflammation. Tar preparations are available in solutions, ointments, lotions, and so on. The drawbacks are they are messy and they do cause staining and have an unpleasant odor. Other topical therapies can be used as well. There are multiple therapies a synthetic form of vitamin D, a medication called Tazarac, which is a derivative of vitamin A. All of these just help slow that cell division down. You can also use ultraviolet light therapy. That does help sometimes with the lesions themselves. Systemic therapy, things like sub-Q injections, IM injections, or even IV therapy. There is a list of drug therapy on page 458. A lot of these are intravenous or sub-Q that can help make those plaque lesions a lot better. And then, of course, we have emotional support. These people need to be touched. You need to make sure you're shaking their hands. Just maybe placing a hand on the patient's shoulder when explaining things. And you don't want to be wearing gloves during these social interactions because this can just kind of be detrimental to this person's self-esteem. This picture is of some more well-known skin cancers. The first picture that we have here is of a basal cell carcinoma. Basal cell carcinomas arise from the basal cell layer of the epidermis, which again is your first layer of your skin. A lot of times they'll go unnoticed, and you don't really worry about metastasis too much with basal cells, but you do have a lot of tissue destruction that can occur, genetic predisposition, and then chronic irritations are risk factors. The most common cause, though, is UV exposure, like sun exposure. Melanomas, which is the second picture up there of the light area, is a pigmented cancer. It arises in where the melanin is in the skin and the epidermal cells. It basically begins as a totally benign growth of a mole. Moles are also called nevus. And remember that your normal moles are regular. They have well-defined borders. They're always uniform in color. They have the same color. They can be light colors to dark colors, but the entire area is going to be the same color. The surface can be rough or smooth. This is a normal occurrence. Where we get into trouble is where you have nevi or moles with irregular or spreading borders, like your last picture down here. You see how irregular that is. You have multiple colors in there. And then other things that can be suspicious, or if you have a normal mole that changes in size, if it starts to grow quickly, or it begins itching or bleeding. Again, risk factors are being out in the sun too much. The incidence of skin cancer is highest among light-skinned people and adults older than 60 years. It occurs more in people that work outside or work in higher altitudes or lower latitudes, or just basically spend too much time in the tanning bed or sun bathing. Other occupational exposures are those that are exposed to chemical carcinogens also. The incidence of melanoma has increased over the past 30 years or so, and it counts for about 45% of all cancers. The best effective prevention that we can do for skin cancer, again, is to reduce how much time we spend outside, or making sure that we're using at least a 30 to 50 SPF sunscreen. And we want to teach people to avoid, tanning beds, salons. Secondary prevention, which is early detection, is critical to surviving with your skin cancers, especially your melanomas, which I failed to mention that this particular picture down here in the bottom is considered a melanoma. So, management of skin cancers. Surgical management, cryosurgery involves destroying the bad cells by putting liquid nitrogen on the cell itself, and this helps to cause cell death and tissue destruction. Curettage and electrodesiccation is actually scraping the cancerous cells with a dermal-like knife. It scrapes away the cancerous tissue, and then an application of an electric probe is put in there, and it destroys any of the remaining tissue. You can excise the skin cancer, basically just take the entire thing off and put sutures in it and then send it for pathology. Mohs surgery is a specialized form of excision that they use primarily for basal and squamous cell carcinomas. It's where they actually section the tissue so that they can look at it underneath the microscope and see if there is any residual tumor cells left. Wide excision is where you do really deep skin resections for really wide and deep skin cancers. A lot of times it goes into the full thickness of the skin, and depending upon how deep that tumor is, you may have also lymph nodes that may be removed. A couple of non-surgical options are drug therapy. There's a medication called 5-fluorouracil. It is a chemotherapy cream that's used for treatment of actinic keratosis, or for any type of a widespread basal cell carcinoma. It requires several procedures to totally get rid of the skin cancers, and then therapy is continued for several weeks. Eventually, these areas become really tender, they hurt, they're inflamed, and these lesions tend to crust and ooze before they finally disappear. And then radiation therapy. Radiation therapy is really limited to older patients who have really large and very deep basal cell tumors and who are not really good risk for surgery. Melanoma is very resistant to radiation therapy. Back on the other slide, one thing I failed to mention, actinic keratosis, which is on page 458 in your book, is a premalignant lesion that arises from the epidermal layer. They're common in people who have chronically sun-damaged skin, either those that work out in the sun for multiple hours a day, or again, who sunbathe. They can progress to a squamous cell if they are left untreated. Squamous cell carcinomas are cancers of the epidermal layer. They can invade locally, and they can also metastasize to other parts of the body. Again, chronic skin damage or any type of a chronic irritation can lead to a squamous cell. Any type of a wound that remains open for a long period of time also puts the person in increased risk for malignancy. So another skin disorder that I need to mention real quick is called a Stevens-Johnson syndrome. You can see with this particular picture, this is actually is a drug-induced skin reaction. It can be mild. It can only have the basic skin involvement, or it can be very serious where it's actually in the systemic system in the bloodstream. The skin lesions are pretty widely distributed. They can also include your mucous membranes. The patient has a mix of vesicles, erosions, and crust. With severe involvement, the patient can have respiratory problems, excess fluid loss, kidney failure, and blindness. So as you can see, this can be pretty serious disease process. We need to, as healthcare professionals and physicians, make sure that whatever medication is causing this, that we stop that medication, and that is crucial to the patient getting better. Mild forms of this are generally pretty limited to about 10 to 14 days, unless a bacterial infection occurs, and then the patient will need antibiotics. Supportive care can include fluid replacement, mechanical ventilation, putting the patient on a vent if necessary, and sometimes even IV replacement therapy. And just to mention a couple of terms, aesthetic plastic surgery is basically cosmetic plastic surgery. It helps to alter a person's physical appearance. Those things like breast augmentations, rhinoplasties, liposuction, those are all cosmetic. Reconstructive plastic surgery is when a patient does something to help improve a functional deficit that has occurred, like if they've got one breast that is smaller than the other breast, mastectomies for breast cancers, sometimes facelifts if it's due to a congenital problem, things along those lines. Well, that is the end of this lecture, and thank you.